hospital, the SCDs need to be on while they're in the bed. If they're at home, TED hose are recommended. Now, does it make a difference if they're knee high or thigh high? Studies say no. It's just as effective to have the knee highs than the thigh highs. The thigh highs never stay up anyway, or if they do, they roll down and look like grandma's hose, and then they cut off circulation. Okay, the knee-high TEDs are just as effective as the thigh highs. It's basically physician preference. Turn off deep breathe. All right, acute pain. Scale 1 to 10. Firm mattress, bed boards are recommended. That doesn't mean that your doctor will write you a prescription for one of those Tempur-Pedic beds, though. Avoid twisting, turning. Assume positions that decrease stress on the back. Analgesic medications around the clock to prevent severe muscle spasms, possibly. Okay? What we want to do is to give them pain when they hurt. Give them pain medication. We don't want to just medicate them every 6 hours whether they're hurting or not, because we really can't tell how effective that pain medication is being if they're snockered the entire time. Chronic pain. Remember, chronic pain, our goal is different. Acute pain, our goal is going to be that that patient reports a pain of 4 or less after interventions. Okay? Chronic pain, what we're going to see is that our goal is going to be that that person can carry out their ADLs in their life. Chronic pain never goes away. They just learn to live with it until it gets to be at a point where it's unbearable. What we want to do is to make sure that we assess their reports of pain and treat them with respect. Just because they're reading a book or watching TV and they tell me that they've got a 7 or 8 pain, doesn't mean that they're addicted to that pain medication and are on drug seeking. People with chronic pain learn to deal with it, and they basically react to it different ways than your patients with acute pain. Treat them with respect. They're telling you that they've got an 8 out of a 10, you medicate them with whatever has been prescribed for that level of pain. Changes in condition, we need to teach them pain management techniques. And sometimes one of those things are those alternative methods of coping. These people will benefit from the acupuncture, acupressure, from the yoga, from physical therapy. Constipation. One of the things that you will see is that with their bowel routine, you want to encourage that 2,500 to 3,000 milliliters a day of fluid. Okay? Unless there's a specific restriction, like they're in heart failure or a kidney failure. The more water you can get in them, the better off they're going to be, because remember that stool forms and it needs the presence of that water to not become hardened and rock hard. Increase fiber and bulk. A little salad never hurt anyone every once in a while. Miralax or Metamucil will help to increase fiber and bulk as well. Stool softeners is needed. These are people that do not need to strain to have a bowel movement. So softeners, Ducasate, Colace, those things are really important to do. about back pain. Okay, let's take another break. And we will do scoliosis. This lumbar lordosis, remember it's sort of like their butt sticks out. See that a lot in pregnancy, but scoliosis, you see that lateral curve. Typically what you're going to see with screening is that it's done in 5th to 7th grade. Most of the time it's a visual observation where the girls are made to sort of strip down to bras and panties, and the nurse will observe them visually from the front, from the back, and then if you have them to hold their hands together and bend over slightly, what you're going to see is this type of problem. Whenever they hold their hands, you can see how uneven and how her shoulder blade sticks up. That's fairly typical with diagnosis of scoliosis. What you will see is that this is the Adams forward bending test. A lot of screening is done in schools by the school nurses, and people that are questionable are sent to their regular pediatrician for further examination, where they might do plain film x-ray, CT scan, MRI to look for that movement. Now, with mild scoliosis, remember it has to be 10% to be termed scoliosis. These are people with 10 to 20 degrees of curvature. Typically, they do muscle strengthening exercises, okay? And that will often improve their posture, their muscle tone, and the flexibility of their spine. What they try to do is build strength toward the outside of the curve while stretching the inside of the curve so that it strengthens and hopefully straightens. But unfortunately what happens is a lot of times that either the exercises are not done or forgotten, and it progresses on to a moderate scoliosis. And this is 20 to 40 degrees of curvature. Typically what you will see is that they will be in a brace, often called a Boston brace, 23 hours a day. They can only take it off to bathe, okay? So that's a nice long shower. Probably the hot water heater would run out a whole lot quicker than an hour. But sometimes they will do electrical stimulation as an alternative treatment in addition to the brace. Severe scoliosis, that 40 to 50 degree curvature, often they will do surgery with a spinal fusion. Now, with a 40 to 50 degree curve, you're going to have someone like this, okay? So, what problems do you anticipate this person with that much lateral curve would have?
Pneumonia?
Pneumonia is a possibility because what they've got is decreased ability to inflate one lung. Okay, what else? They may fall because balance would be off. Okay? But think about these 10 to 13-year-old girls with body image. Low self-esteem is going to be an issue.
Wouldn't they also have like hip problems and stuff?
Hip problems may...
Because it's like uneven.
Right. Going to be uneven hips. So your gait may be off. Okay? Where on the side where you've got the majority of your curve might be a little bit more. Typically what you see is that surgery will stabilize the spine, and after a period of post-op bed rest, they are fitted with a thoracolumbar sacral orthotic, basically a brace that they would wear to until that spinal fusion is completely healed. So that what it doesn't do is slip back into place. Surgical wires in this situation would remain in the back forever, and the instrumentation basically stays in place, because that way, as the person grows and gets taller, it may have to be revised, but that instrumentation does stay there. It's not, well, we'll leave it in 5 years and then take it out. Now, these are some types of the orthotics. One of my favorite movies, 16 Candles. This is the old style brace that they would use. If you've never seen this movie, it is phenomenal. Oh, sexy girlfriend. Okay. Yeah, long duck dong. Great movie. Yeah, it's one of the most favorite movies. But anyway, this is the type of brace that they used to wear. Sometimes you will still see these types used, though often you will see this type of brace over here. And it does go on outside of clothes to decrease irritation. Typically what we tell them to get is like a white t-shirt to put underneath, or a pair of like boxer shorts, or boyfriend panties or something like that, because you can see that you will not only have the straps up here, but you have the straps that go through the crotch. Okay, so irritation is an issue if you don't wear something under it. This is what it looks like. Again, 23 hours a day.
That is so annoying to put on.
Yep, because what you find is that not only is it uncomfortable, but think about it this time of the year, it'd be hot. Okay? This is what the spinal fusion looks like, and you can see that they've got the rods and the screws in here, and it's a multi-level fusion, because what they're trying to do is to correct that curvature of the entire spine. Okay, this is major surgery. Okay, it takes a while in the OR, so you have the increased risk of lung anesthesia. You have an increased risk of pneumonia. You have an increased risk of problems with fluid and electrolyte disturbances, okay, because of the amount of times that it takes in that OR. Nursing diagnoses that you see with these young women, though there are some boys that will have scoliosis, it's fairly more common in women. Ineffective self-health management, impaired physical mobility, impaired wrist skin integrity, okay? Braces and or surgical incision, ineffective breathing pattern, readiness for enhanced knowledge related to care, okay? Teaching them those exercises, teaching them how to use that brace appropriately, and then definitely disturbed body image. Basically, what we want to do is to make sure that they know how to take care of themselves with either those exercises, the braces, or the post-surgical care. We want to provide reassurance and encouragement, because after that surgery, they may be out of school for a while, a couple of months, several weeks, where they would have to stay out and be homeschooled for a while. We want to promote interaction with their peers, and then what clothing to wear with that brace. Again, the t-shirt or the boxers underneath to prevent skin erosion, and then clothes on over the top of it. Questions about scoliosis? right, the majority of time what you'll see is that if the exercises don't work, they move on to the brace. If the braces don't work, then surgery is the last resort. Okay? But it has to be done if it's that 40-degree curvature. All right, traumatic injuries. Nice old ankle turn here, and you can tell by look how fat that ankle is and how bruised it is. All right, traumatic injuries, strains, sprains, contusions. Contusions are the least serious of the musculoskeletal injuries. Basically, you've got bleeding into the soft tissue that results from the blunt force. This is you running into the doorknob with your hip. Okay, you get a bruise. A strain is stretching injury to a muscle or tendon caused by mechanical overloading. In other words, you twist it the wrong way. A sprain is a tear of a ligament that surrounds a joint. So strains and sprains, you rice them. Rest, ice, compression, and elevation. Okay? Rest, meaning that if it's your ankle, you put your ankle up and you don't walk on it for a while. Ice, typically we're going to do 20 minutes on, 20 minutes off. Okay? Never, never, never put heat on a fresh strain or sprain, because what does heat do? It promotes blood flow to the area, and so what's going to happen to our swelling? It's going to pop up. Okay? Ice causes vasoconstriction and therefore will decrease swelling. However, if you leave the ice on too long, it will cause frostbite, which is a burn, and we don't want that. Compression. Ace wraps or one of those compression sleeves or some type of splint may be indicated. And then elevation. Okay? We elevate to decrease swelling. So rice. Fractures, as a rule, are beyond that strain and sprain and contusion. What you typically see with fractures is it's a break in the continuity of the bone. It occurs when that bone is subjected to more kinetic energy that it can absorb. Either a direct flow from like a swing from a baseball bat, crushing force, like the furniture that you were moving fell on your toes, twisting motion, you reach to catch something, severe muscle contraction. We see that a lot with our patients that have had severe burns or electrical injuries, because electrical injuries, a shock, will cause muscle contraction, and I've seen fractured bones from that. Diseases that have weakened the bone, like your bone cancers or your osteoporosis. Pathophysiologically, what you're going to see, closed fracture, open fracture. I don't know if these pages still work or not in the 8th version. I think I checked them, but I'm not sure. But it's in their chapter somewhere. Closed fracture just means the skin is intact. Open fracture means that the skin integrity is interrupted. You may hear it called a compound fracture instead of an open fracture. Sometimes that fracture line can be oblique or spiral, and I'll show you what those mean in just a second. The fracture can be complete, meaning that it's broken all the way through, or incomplete, meaning that it's only broken partially. Remember, we were talking about those green stick fractures that you often see in kids, where they don't break all the way. They splinter on one edge and they're intact on that bleeding edge. Stable fractures, okay? Think of this as a femur bone. A stable fracture means that it is in alignment. And even though that it's broken here where my hands meet, it's still in alignment. Unstable fractures means there's displacement, okay? Which means that if I've got a displaced fracture, with movement of that leg, what that bone can do, those sharp edges, can continue to cause muscle trauma. Basically, this is the thing I wanted to show you, the open fracture. There's a break in the integrity, often caused by the bone, okay, where the bone slips out of the skin. Closed basically means the skin is intact. Fractures in children, often direct trauma, and unfortunately a lot of times it's caused by child abuse. It may be caused by bone disease. Green stick and spiral fractures are very common in children. And by spiral fracture, that's usually done by a twist. Okay, and what happens is the fracture occurs and it looks like a spiral on the bone. Fractures in adults are more commonly caused by trauma, bone disease like osteoporosis, or overuse. This is what a green stick fracture looks like. See, it's broken on this edge, but this edge is intact. That spiral fracture, basically it looks like the arm has been twisted and the bone has gotten a lot of pressure on both sides. And so what it does is it splits, instead of crossways, it splits up and down along a longitudinal surface. So that if I take a child's hand and twist them and say, come on down this mall with me, or jerk them, okay? A lot of times what we see is called that spiral fracture. You can also see mall arm. It's M-A-L-L arm. Basically what you do is you jerk their arm and they get numbness and tingling because what you've done is jerk their brachial plexus and they may have an arm that no longer works. Okay? So be careful whenever you're dragging your little 2-year-old along to make sure that their arm is in a neutral position and not like this. Okay? All right. Bones heal. Do you understand what I'm saying? The one thing you do need to remember is that whenever they do heal, they typically form what we call a bony callus, meaning a little knot of bone growth, so that you can see how smooth these edges are. See how enlarged it is? That callus forms, and that's what causes the heal. All right. So, clinically manifestations. What will we see with a fracture? We see soft tissue injury. A lot of times bruising. If it's an open fracture or compound fracture, you may see bleeding. You may see deformity. Okay? Any of you ever seen the Joe Theismann football injury? Okay? It's one of those things that it was after a while, why do you keep having to replay this? Because every time people go like this, or remind me, I can show you the guy that was playing Duke in the
Oh God, that was so sad.
yeah, and I mean, 3 people on the Duke team threw up when they watched
People on the
that.
sidelines are the best because they just look and then they notice.
Yeah, it's great. It's great. But, he had a spontaneous fracture because he just placed his leg wrong and it just went right down on the floor. But deformity, pain, tenderness, you will see people guard. And by guarding, I mean don't touch it. Don't you even think about touching it. Okay? Or they will remove it. see hypovolemic shock from femur fractures or hip fractures, because those areas are very vascular, and it will not be unusual for hypovolemic shock to occur. Remember, with that, we're looking for low blood pressure, we're looking for tachycardia, we're looking for increased respiratory rate. Ecchymosis or bruising, swelling, numbness, crepitus. What does crepitus sound like? Cracking or crunching or grating. Okay? Muscle spasms often occur because of the pain. Some of your complications, this is a KDOD, acute compartment syndrome. Basically, you have entrapment of blood vessels that limits perfusion. It can result in the loss of their limb or sepsis. Okay? Typically what you will see is that you've got someone that has a splint, a cast, an ACE bandage, or something that's an external force that is too tight because of the amount of swelling that they've got. And so what happens is that the muscles in that compartment start to lose blood flow. So what you will see is that you will have the 6 P's to assess for. And if compartment syndrome occurs, this is one of the things that you're going to definitely call the healthcare provider about and get some help there. Because either that splint or that wrap or that cast has to come off for them to be able to salvage that limb. Okay? Now, let's just talk about that. I said talk to the healthcare provider. Now, what have they told you about test-taking strategies in the first level?
And never call a healthcare provider first.
Right. But I'm going to tell you, this is second year, and there are certain things that you're going to call the healthcare provider as your priority intervention. If there's nothing that I can do to relieve this pressure, if it's a cast, I can't cut that cast off. But I can get the healthcare provider that can order that cast to come off. Okay? So don't automatically discard calling their healthcare provider as your priority option. Because I'm going to tell you, you're going to see it. Because at this point in time, in the rest of your nursing career, you're going to be the one that has to make that decision. Do I call the healthcare provider or not? All right. That's the difference between first level and second level. Second level, it can be your priority prevention. So I want to remove that tight cast so that I can increase my blood flow. All of you that have worn support pantyhose, if anyone even wears pantyhose anymore, you know that one of the first things that you do when you take those suckers off is that you breathe a whole lot easier, okay? That's the same thing with removing that splint or that cast. That tissue is able to perfuse. And I will tell you, if they've had perfusion problems to the point of decreased blood flow, when you get that cast off, they will have numbness and tingling like crazy. Okay, you know how that whenever your foot falls asleep, that's because of decreased blood flow? Whenever it starts waking back up and getting that blood flow back in, it hurts like the dickens. You will see that. The other thing they may have to do is fasciotomy. And that's to cut the muscle fascia to relieve that pressure. Now, we have to do this a lot in our patients with burn injuries. Because with burn injuries, it's the tissue itself that's hardened and causes that compartment syndrome. And sometimes what we have to do, especially if it's on the chest, is just make incisions and slits, leave them open for them to be able to do chest wall problems. The incision is left open, and we do passive range of motions on that extremity. This is what a fascia, let's see, where is it? This is the way that we check the pressure. You insert a little needle in there with a pressure gauge, okay? It's a pretty big needle, but what you're trying to do is to feel what that pressure is in that muscle, and then they just split the fascia to relieve the pressure. Leave that open, so what you see is that if I've got this big wound like this, what's some of my nursing care going to be? Infection control. Okay? Yeah, they're going to leave it open, but I may put a loose dressing on it to keep it clean, dry, and intact. And I'm going to make sure that I am watching for signs of infection, like any drainage, any fever, any types of abnormal appearance about that wound. Yes?
I have chronic compartment syndrome. So whenever I ran track and field and played soccer in high school, and the kind of pain that you get from chronic compartment syndrome is the worst. It feels like your legs are on fire, and you keep feeling any of your toes. And mine actually herniated because the pressure was so high, and I had to have that meter stuff done. I didn't get to have them done at the same time, but I had to have both legs done. So I have weird scars on my legs from having to do all that stuff, and it's awful.
And they do just leave it open, so you get a very wide-looking scar. It's not the prettiest thing in the world, but it's better than losing your leg. Typically, one of the things that I am going to do as a nurse to assess, to see if this patient is developing compartment syndrome, is neurovascular checks. And I'm going to do these as often as it's necessary to assess for that change. We're going to look for pain, pallor, polar, meaning temperature, okay? Paralysis, paresthesias, and pulselessness. So we're going to do these P's. So what do you think would happen first?
Numbness and tingling.
You're going to see the paresthesias, numbness and tingling. Then what you see next?
Pain.
Pain. What would you see next?
Pallor.
Pallor. Pulseless, polar, and then paralysis. So those paresthesias, that numbness and tingling, and like she said, her legs felt like they were on fire. And that's typically what you're going to see. Those legs feel funny of some sort. That either tingling sensation like you see whenever your foot's asleep and then you try to pound it out to get it to wake up type thing. But pulselessness and paralysis are going to be what you're going to see as later signs. It's always best to check. We're looking for cap refill. We want that cap refill within 3 seconds. We're looking at the amount of swelling. We're looking to see, is that cast too tight? Is there a significant amount of swelling there? Typically, what you will see is that if there's a significant amount of swelling with that fracture, they don't cast immediately. Sometimes what you'll see is that you come into the emergency room with a broken arm and it's swollen. They'll wrap you up in a splint and say, see the orthopedic guy in 2 days. Well, don't I get a cast? No, you're too swollen, because what they're trying to prevent is this compartment syndrome. Okay? So know what your P's are. The other thing that can happen from compartment syndrome is this is called a Volkmann's contracture. And it can happen from unresolved compartment syndrome. It's a common complication of elbow fractures, and what you see is arm immobility. How functional do you think this wrist and fingers are? Not very. Okay? So Volkmann's contracture, see how contracted that hand is? They may have finger movement, but they will not have the ability to move that wrist in order to bathe, dress, or feed. Okay? So Volkmann's contracture you typically will see if that is unresolved in the arm. Now, fat embolism syndrome. Fat embolism usually occurs when fat globules from the bone marrow lodge into the pulmonary vascular space or in somewhere in the peripheral circulation. I've seen strokes occur from this as well. What you get is altered level of consciousness and confusion. You will see pulmonary edema, impaired surfactant production, atelectasis, and typically, if this is not caught early enough, they develop ARDS, or adult respiratory distress syndrome. And they will have respiratory failure. Basically, they typically will try to prevent it or recognize it early and make sure that if it's recognized, they give steroids to decrease the inflammation in the lungs. Typically what you see is mental status changes, dyspnea, chest pain, a petechial rash on the chest, and it looks just like this. It just looks like little petechiae all over the chest. Basically, you will see it from pelvic fractures, long bone fractures like femurs, and major trauma. Took care of an 18-year-old that broke his right femur with motorcycle accident. Only reason that he was in the hospital is that he had some swelling, and they couldn't cast him, and his mother worked at the hospital. Only reason they hospitalized him. Otherwise, they would have wrapped him up and sent him home and said, see the orthopedist tomorrow. Well, I was taking care of him, and then laughing, joking, and talking. 1 minute, the next time I checked on him, an hour later, he was confused. And he says, I'm having problems breathing. And I looked at his chest, and he's got this rash. He had thrown a fat embolus. He eventually, from the time he had his fracture to the time that he threw that fat embolus was about 15 hours. At 24 hours, he was tubed in on a ventilator because his lungs developed a severe flash pulmonary edema from that fat embolism and had to be supported for 3 days on the ventilator. If that guy had gone home, he would have died in his sleep. But typically what you see is that respiratory problem that eventually leads to respiratory failure. But fat embolism, you need to assess for it, especially pelvic fractures or long bone fractures. You need to make sure that you're doing good respiratory assessments and looking at their level of consciousness and assessing for confusion. Okay? Because remember, confusion and restlessness is going to be one of your first symptoms that you're going to see from low oxygen levels. Doesn't matter the age. Acute confusion, one of the first things I always do is check the O2 sat, and if I can, get an ABG. Because oxygenation is going to be one of your primary reasons for confusion. Alright. Let's do DVT, and then we'll call it a day. DVT, or what we are now terming VTE, venous thromboembolism. Deep vein thrombosis, often what you will see is that patients with fractures, specifically leg fractures that may be casted or intraction, are at high risk for development of DVT and VTE. Basically what you've got is you've got these three precursors. It's called Virchow's triad, if you really want to know. You got venous stasis, you got injury to the vessel walls, and you've got altered blood coagulation. And basically what that does is it sets them up to develop that DVT. Swelling, leg pain, tenderness, cramping are some of your signs that you would see. You typically see a color change in that leg because of venous congestion. You often will see a temperature change because the temperature will be hot. Okay? What we want to do is to prevent them at all costs. Early immobilization of that fracture and early ambulation. Early immobilization of the fracture will also help to prevent fat embolism. But what we want to do is to get them up, get them moving. And what else are we going to do? What's your VTE protocol in your hospital for anyone on bed rest? SCDs and anticoagulants, like your heparin injections or your Lovenox, Enoxaparin, or Rixtra Fundarepam. Okay? So those types of medications, you're going to give them something to increase their coagulability so that they don't develop that VTE. Okay? This is a little bit, we want to go a little bit beyond aspirin and antiplatelet stuff. We actually want to affect one of the clotting factors here. Example, look at this leg. Look at this leg. See how swollen it is? That's from the venous congestion. It's sort of reddish purple, again, from the venous congestion. Now, what do we tell you to check? Coleman sign. It's worthless. I mean, we tell you to check it, we teach you to check it, but basically what we found is that for determining if this patient has VTE or DVT, it's a worthless test. Okay? Look at the difference in leg size. Look at feel the difference in temperature. Look at, I usually check calf circumference. I take a measuring tape and literally measure. And making sure I'm getting it in the right place, put a little line where I want my tape measure to go so that I can measure appropriately at the same time. Okay? We definitely want to prevent DVT with these patients because this is going to be one of the things that's going to lead to death. Pull